So anyway, as tissue gets heated up, it has different responses. I didn't put the aroma on here anywhere, but from 40 to 60 degrees Celsius, we can, 60 to 90 degrees Celsius, we can induce something called protein denaturation. Proteins are long-chain molecules that allow our bodies to do the things that it does, and they typically are folded up in very specific ways, and they're held together in the folded patterns by, ionic bonds. But these can be broken with thermal energy. So if you vibrate it enough, it'll break those bonds, the proteins will unwind. But you're not heating it up to the point where you're actually taking the proteins apart. You're just breaking those connective bonds. So what we'd like to do is heat up the proteins, allow them to unwind, and then when they cool down, they'll wind back around to each other. And that potentially is a way that we can fuse tissue together. Basically, we make it gooey. So you heat it up, it gets a little gooey, you stick it together, it cools down, and you have an instant watertight seal. If you look at temperature on this axis and the amount of time you hold tissue at that level, typically, and this is just a generalization for tissue, in that 60 to 90 degrees C range, you'll see you can't really hold it for a long time before you get into this irreversible tissue damage. So we're looking at on the order of a second. But if we can get some way of heating tissue up to that temperature over a short period of time, make it gooey, then when it cools back down, the damage is reversible and the proteins will curl back up. A nice thing about using lasers to heat up tissue is because, as this simple example shows, where we're going to butt weld these two things together, if we relied on just surface heating, then we would have to wait for conduction to carry the heat through the tissue. Well, conduction takes time, as this part causes this part to be hotter and you get a gradient, and it takes a while for the heat to propagate through, because the light can actually penetrate into the tissue and act on constituents in there. You can heat a volume of tissue simultaneously, as opposed to waiting for the surface conduction through just something touching something hot and waiting for the heat to get through. So if we bring these two pieces of tissue together, and these coils represents the proteins, we heat it up with a laser, they unwind, reach across that interface, we cool it down, you get a bond. And here's an actual photograph of two tissue slabs that were fused together. And at least qualitatively, this is histology. We took a slice, dyed it. It looks pretty good. It used to be two separate pieces of tissue that we stuck together along that line. So it looks promising. And in the lab, we're taking these little slabs of tissue. They're small, about 1 centimeter by 1 centimeter and 1 millimeter thick. And we are stacking them up on this tissue supports table, one over the top of the other. And then we bring this load cell down so we know how hard we're squeezing them. This is a laser that sits over here, and it provides laser light through a fiber optic cable that comes up underneath here through an aperture. It illuminates that tissue, and what we get is, this is a close-up. So there's the two tissue specimens stacked. We fire the laser from the bottom. There's an example of a tack weld for two of these tissue slabs that are stuck together. And here's my lab assistant with forceps trying as hard as he can to pull those two apart, and he just can't do it. Actually, that's not true, but it does stick together. He can pull it apart, only because he's very strong. Yeah.
When you pulse it, does it come apart at the joint, or does it come apart where you tack weld it together, or is the failure somewhere else?
The only place they're joined is where we tacked them together. So at that one spot.
So that would be the failure point.
Right.
Okay.
Yeah. So we've got two things. We stack them up, and then we stick them together at that one place. And right now we are actually trying to get a profile of tensile strength with time. But again, we're using tissue that has been separated from its host, so it is going to act a little different. We don't really expect this to heal over time the way a body is going to heal over time. So the application that we're after is nasal septal deviations. So this is the first application where I'd like to use lasers in a surgical instrument to stick tissue back together. And one reason that I like this is I know this application very well, and I think it's tailor-made for this application. So we've got nasal obstruction. Here's a fellow that the front of his nose was lopped off. So you know the poster for Pirates of the Caribbean? You look in the hole in the front of the skull, you've got that little bone right in the middle. So that's the septum, and it's a bony structure. Sits here between the two sinus cavities. There are the eyes. And if that's crooked, the bone is crooked and the cartilage is in front of it, there can be a number of pesky things that result. And so it's very common, in fact, over 500,000 a year in the US, where people will have that bone removed so it won't be crooked anymore down the middle. So here is a cross-sectional view. If you were to cut away half of my head, not right down the middle, just slightly off center, here's the tip of my nose, here's my nostril, and my eye would be up here with my mouth down here. And this is a cartilage plate, and that's what is the soft part of my nose. Behind it is a bony plate, and that's what you see in the front of the skull. And what the physician will do is go in and remove that bony plate, and some of the cartilage will come with it just to take out a hole. But there are tissue flaps. If you stick your finger up your nose, you can feel that there's skin on both sides of that cartilage and bony layer. So those are lifted up, the stuff is removed. Now we have to stick those two tissue layers back together. And here's some shots from an actual surgery. Here's the two nostrils of the patient. They have this speculum instrument which enlarges a nostril more than a nostril was ever intended to be enlarged. The patient is asleep. They have the eyes covered with tape just in case she wakes up. She can't see who's doing this to her, I guess. And they have to work through the nostril, and what they do when they're working through here, there's an incision that's made right here at the base of the nose. Here's a diagram. And then they take just a spatula and elevate the tissue from one side. And then they bust through to the other side and elevate the tissue off the other side. And then they take their Sears Craftsman needle nose pliers, reach in there, grab the bone sharply, and give it a twist. That's really what they do. And they pull out the chunks of stuff. Now here's that patient. This picture is just supposed to show right now the way they stitch those two flaps back together is using suture. And I don't know if you can see back there, but there's suture coming out this side, and there it is there. And it is very difficult to do this because you have to work through the nostril, and you're sewing 7 centimeters back into the nasal cavity, where you have to stick the needle in one side and then go up and grab it, turn it around, stick it back through, go up this nostril, grab it, and stick it back through. And the first time I observed one of these, I was with a physician, and there was a resident there, and the physician did the septoplasty, and when he got to this closure part, he turned to the resident and said, "Go ahead and close it up." And she looked at me and she said, "I hate this part." And sure enough, in fact, we did a study where it takes, on average, about 12 minutes of operating room time just to do this closure because it's a pain. What will often happen is the needle will catch the outer wall. There are these structures called turbinates that are very vascular. They're the things that add moisture to the air that you breathe, so your lungs don't take the no humidity Colorado air. And when the needle nicks that, it starts bleeding because it's vascular, but now you have two surfaces that have been really roughed up, and tissue ligaments will actually grow across that gap. And so the physician, after stitching this up, will put splints up the patient's nose, just long popsicle sticks, basically, to prevent those synechia or ligaments from forming. And so they stick them up and they tack it together with one suture. But in this first one, when the woman said, "Oh, I hate this part," the patient, of course, is lying on her back. And I saw this woman take a splint and slide it up one nostril. She then turned around to get the other one, and I was watching, and it just disappeared from sight. And she turned around and let loose a couple expletives and had to go after it. So anyway, I just mentioned that. That was a great experience for me. So the current surgical methodology is to use this suture. Now, it used to be that people would just roll up gauze because it's such a pain to do this suture. You just roll up gauze, stick a roll up each nostril, and that would hold the two layers of skin together down the middle, but you also can't breathe because you have these rolls of gauze up your nose, and they'd leave it up there for 48 hours. So can you imagine what it's like? And isn't just like, a Q-tip in the end. This is all the way back up there. But that has fallen out of favor because it's been linked to toxic shock syndrome. So people don't like to do that anymore. So they do this time-consuming thing. You really have to, because if you don't tack those two tissue layers together, then it'll fill with blood and a hematoma will form, and it will starve the cartilage that the physician leaves to give your nose shape. The cartilage gets its nutrients from that skin layer, so if you don't close it up,